Chapter 10, Blood. So blood is unique as it is the only fluid tissue in the body. It appears to be a thick, homogeneous, so all of the same material kind of liquid, but microscopically it has both solid and liquid elements, which we'll talk about here on the upcoming slides. So blood is charged with transporting oxygen, nutrients, and other substances throughout the body, and participates in processes that are important to our bodies like clotting and fighting infections. It moves through your blood vessels by the pumping action of the heart, which we'll learn about, I believe, in the next chapters, cardiovascular. This fluid contains red blood cells to carry oxygen, clotting proteins to stop bleeding, and white blood cells to fight infections. And the why, transportation via blood is the only way substances can be moved to distant locations. So we just learned in the endocrine chapter that this is how hormones travel as well. In addition, clotting proteins are found only in blood, so without them, a minor cut could turn into something more life-threatening. So just to reiterate, blood is unique, and that is the only quote-unquote fluid tissue in the body. Appears to be this thick, very same material liquid, but it's actually both solid and liquid components. It transports everything that must be carried from one place to another. So nutrients, hormones, waste, body heat. It's sometimes called the river of life. So blood is this complex connective tissue in which living body cells, blood cells rather, the formed elements are suspended in plasma. The collagen and elastin fibers typical of other connective tissues are absent from blood. Instead, dissolved proteins become visible as fibrin strands during blood clotting. When a sample is separated, which you can see in the image here, the plasma will rise to the top and the formed elements, being heavier, fall to the bottom. Most of the reddish at the bottom of the tube is erythrocytes, or red blood cells, and the formed elements these are the formed elements that function in oxygen transport. There's a thin whitish layer called the buffy coat at the junction between the erythrocytes and that top layer of plasma. Sometimes it's just barely visible, and this layer contains the remaining formed elements, the leukocytes, so your white blood cells, that act very primarily and importantly in your immune system. Platelets, which are the cell fragments that help stop bleeding, so also very important. Red blood cells normally account for about 45% of total volume of the blood sample, and this percentage is known as the hematocrit. White blood cells and platelets contribute less than 1%, and plasma makes up the remaining 55% of whole blood. So you can see here in the diagram that the 55% of plasma is made of water, salts, plasma proteins, and then substances transported by blood. And then the formed elements, you have your red blood cells, your leukocytes, and your platelets. And we'll talk more about each of these things a little more in depth. Let's talk about some of the physical characteristics and volume of blood. So blood is sticky, opaque. It's heavier than water and about 5 times thicker, or what we would say more viscous, and largely because of those formed elements. Depending on the amount of oxygen it's carrying, the color of blood will vary from very scarlet, so super deep red, meaning it's oxygen rich, to a dull red or purple, meaning that it's oxygen poor. Blood has a characteristic metallic salty taste. I'm sure we've all tasted it. This is something we often discover as children, if we cut our finger and, put it in our mouth to stop the bleeding or bite our tongue. Blood is slightly alkaline with a pH between 7.35 and 7.45. Its temperature is usually around 100.4 degrees, always slightly higher than body temperature because of the friction produced as blood flows through your vessels. So the actual flow itself generates heat. Blood accounts for approximately 8% of body weight, and its volume in healthy adults is 5 to 6 liters, or about 6 quarts. Let's talk a little bit more about plasma. As I just said, Plasma makes up about 55% of the blood, and it is the liquid component of blood. It is made up of about 90% water, and it's straw colored, made up of over 100 different substances and solutes, including nutrients, salts, so electrolytes, respiratory gases, hormones, plasma proteins, and various waste and products of cell metabolism. Plasma proteins are abundant, and they are mostly made by the liver. Albumin is a carrier to shuttle certain molecules through the circulation, is an important blood buffer, and contributes to osmotic pressure of blood, aka it keeps water in the bloodstream. So this is something we will use clinically sometimes to help maintain blood pressures, because we call it a quote-unquote fluid expander. If you infuse or transfuse albumin into the circulatory system, water will be better retained into the circulatory system, increasing blood pressure. Clotting proteins, which helps stem blood loss when a blood vessel is injured, which we'll talk more about that further on in the lecture. And then antibodies, which I'm sure we've all heard of, that help protect the body from pathogens. Plasma proteins are not taken up by cells to be used as food fuels or metabolic nutrients, as are other solutes such as glucose, fatty acids, and oxygen. The composition of the plasma will vary continuously, but is kept fairly constant via mechanisms of homeostasis in a generally healthy person with a healthy diet. Various body organs make adjustments to maintain plasma solutes at life-sustaining levels. For example, when your blood proteins drop to undesirable levels, your liver is then stimulated to make more proteins. And when the blood starts to become too acidic or too basic, both the respiratory and urinary systems hop into action to help normalize it back to that slightly alkaline pH. Plasma does help to distribute body heat, a byproduct of cell metabolism, evenly through the body. Now let's move from the plasma to those formed elements. So the first that we're going to talk about are erythrocytes. So these are your red blood cells. They function primarily to carry oxygen throughout the body, so quite important. They're anucleate, so they have no nucleus, and they contain few organelles. Mature red blood cells are just quote-unquote bags of hemoglobin molecules. Hemoglobin is an iron-bearing protein and transports most of oxygen in the blood. It'll also bind a small amount of carbon dioxide, but not at the same binding site. It also is super efficient at doing this because it doesn't require any oxygen in order to transport the oxygen. So it's not using oxygen to transport the oxygen. So it's an excellent mechanism for this. You can see the image at the top. It's a small flexible cell shaped like a bioconcave disc. They outnumber white blood cells, so leukocytes, 1,000 to 1, and it's the major contributor to the thickness, the viscosity of the blood. A single red blood cell contains 250 million hemoglobin molecules, and normal blood contains about 12 to 18 grams of hemoglobin per 100 mLs of blood. And your leukocytes, so these are your white blood cells. As we said before, they're less numerous than the red blood cells, about 1 for every 1,000 red blood cells, but they are very, very important to our immune systems. On average, a person will have 4,800 to 10,800 white blood cells per millimeter to the third of blood, but it makes up about less than 1% of your total blood volume. Diapedesis. This is when, red blood cells are your erythrocytes are confined to the bloodstream. White blood cells, however, are able to slip into and out of blood vessels. This is called diapedesis. The circulatory system is simply their means of transportation to areas where the body needs them. So places where you're having an inflammatory response, you're having an immune response. So it uses the circulatory system as a highway and then takes the exits of the blood vessels to where it really needs to work. And then in addition, white blood cells can locate areas of tissue damage and infection in the body by responding to certain chemicals that diffuse from damaged cells. This capability is called positive chemotaxis. Once they have quote unquote caught the scent, the white blood cells move through the tissue spaces by amoeboid motion. So they form flowing cytoplasmic extensions that help them move along. By following the diffusion gradient, they pinpoint areas of tissue damage and rally around in large numbers to destroy microorganisms and dispose of dead cells. Another really cool function is when they're needed, they will begin to replicate faster. That's why if somebody is ill, somebody has been injured, if we are to draw their blood within that next few hours, we're going to see an increase, sometimes of almost twice as many, from 10,800 to almost 20,000 of white blood cells present in the blood. The condition of leukocytosis, or the designation of leukocytosis, is any count above 11,000, and leukopenia is a low count. Leukopenia is commonly caused by certain drugs like anti-cancer agents and corticosteroids. White blood cells are classified into two major groups, granulocytes and agranulocytes, depending on whether or not they contain visible granules when stained in the cytoplasm. And we'll look at some of the specific characteristics a few slides from now on a nice little image chart. And then we have platelets. So these are not technically cells. They are fragments of multinucleate cells called megakaryocytes, which pinch off to make these anucleate platelet pieces that then seal themselves off to that surrounding fluid. The platelets appear as darkly staining, irregular shaped bodies scattered among other blood cells, and the normal platelet count in the body is about 300,000 per millimeters cubed, or to the third rather. Platelets are needed for the clotting process that stops blood loss from broken blood vessels. Like I said, we'll explain more of that process a little later in the lecture. So we can see in the image on the left that the majority of what we're looking at are erythrocytes, so red blood cells. You can see the tiny little cells among them, and those are your platelets. And then all of those other cells they look kind of abnormal. These are going to be your different variations of white blood cells. So the chart does a really good job of breaking down what it looks like, what the function is. So we talked about it already. Erythrocytes are more plentiful than leukocytes by 1,000-fold. They are salmon color, bioconcave, anucleate, and they transport oxygen, and they also transport a small amount of carbon dioxide. So the granulocytes, so those white blood cells with visible granules on staining, are neutrophils, eosinophils, and basophils, and you can see the occurrence in the blood. Neutrophils, they stain pale pink and contain fine granules, which are difficult to see. Deep purple nucleus consists of 3 to 7 lobes connected by thin strands of nucleoplasm. They're active phagocytes. Number increases rapidly during that short-term or acute infections. Eosinophils are red coarse cytoplasmic granules. Figure 8 or bilobed nucleus stains blue-red. They kill parasitic worms by deluging them with digestive enzymes and play a complex role in allergy attacks. And then basophils. The cytoplasm has a few large blue-purple granules, U or S-shaped nucleus with constriction stains dark blue. They release histamine, which is a vasodilator chemical at sites of inflammation, contain heparin and an anticoagulant. And then your agranulocytes. So the ones that show no granules, we have lymphocytes and monocytes. So lymphocytes, the cytoplasm is pale blue and appears as a thin rim around a nucleus, mostly spherical, dark purple blue nucleus. It's part of your immune system. So we learned a little bit about lymphocytes in the endocrine chapter, and the fact that they are created from thymosin, which is created in the thymus, which is technically an endocrine gland. So B lymphocytes produce antibodies. T lymphocytes are involved in graft rejection and in fighting tumors and viruses via direct cell attack. And then the monocytes, they're abundant gray-blue cytoplasm, dark blue-purple nucleus, often U or kidney-shaped. Active phagocytes that become macrophages in the tissue. So long-term cleanup team, increase in number during chronic infections, activate lymphocytes during immune response. And then again, the platelets, you can see they're small, irregularly shaped, and they stain this deep blue purple. On this image, it's hard to see that they're deep blue purple, but some of them do appear that way, and obviously needed for the clotting cascade. So you can kind of compare the image on the left to the descriptions on the right. You can see the monocyte all the way to the left, that U-shaped nucleus, the lymphocyte, a very thin cytoplasm around a very round disc-shaped nucleus. The neutrophil, you can see the granulocytes in the cytoplasm, and then the same thing with the eosinophil. I want to briefly talk about some of the different types of anemias that can occur in the human body. So just being a homeostatic imbalance of the system. So we have hemorrhagic anemia, which is pretty self-defining. We have a lack of blood related to hemorrhage. Hemolytic anemia is when red blood cells lyse, so they rupture as a result of bacterial infection. Pernicious anemia is a lack of vitamin D, usually due to a lack of intrinsic factor required for absorption of that specific vitamin. An intrinsic factor is formed by stomach mucosa cells. Aplastic anemia is just related to depression or destruction of bone marrow by cancer, radiation, or certain medications. Iron deficiency anemia, so a lack of iron or slow or prolonged bleeding, such as heavy menstrual flow, a bleeding ulcer, depletes iron reserves needed to make hemoglobin, and red blood cells are small and pale because they lack hemoglobin. And then sickle cell anemia. So this is a genetic defect that leads to abnormal hemoglobin, which becomes sharp and sickle-shaped under conditions of increased oxygen use by the body or low oxygen levels in general as they occur. It generally occurs in individuals of African descent. So you can see in the image to the right the comparison of A. So that you have the normal erythrocyte, which is nice and concave, oval, and then the sickled erythrocyte directly next to it. So if you can think about the way blood travels through the body, it travels through blood vessels. So kind of like let's liken it to a water slide with a little more friction at a water park. You know, so the tube that you're using to go down the water slide is round, like a healthy erythrocyte. When it sickles like that, a lot of times it can get stuck, it can catch, and this makes for a really, painful presentation of the patient, issues with shortness of breath because their O2 is not circulating as well. Even more quote unquote normal life happenings like pregnancy, can cause real issues for somebody who has sickle cell anemia. Hematopoiesis, aka blood cell formation. So this occurs in the red bone marrow or myeloid tissue. In adults, the tissue is found chiefly in the axial skeleton, pectoral and pelvic girdles, and the proximal epiphyses of the humerus and femur. Each type of blood cell is produced in different numbers in response to changing body needs and different stimuli, and after they mature, they are discharged into the blood vessels surrounding the area. On average, the red marrow turns out an ounce of new blood containing 100 billion new cells every day, which is crazy. All formed elements arise from a common stem cell called a hemocytoblast, also known as a blood cell former, which resides in that red bone marrow. Their development differs, however, and once a cell is committed to a specific blood pathway, it cannot change. The hemocytoblast forms two types of descendants. the lymphoid stem cell, which produces lymphocytes, and the myeloid stem cell, which can produce all of their classes of formed elements. So in the image on the right, we're looking at how the blood cells are formed. So all blood cells would differentiate at the hemocytoblast stem cell in the red marrow, pardon me. And you can see from at the top, the hemocytoblast stem cell, it'll either become a lymphoid stem cell, which is charged with making lymphocytes, or a myeloid stem cell, which is charged with everything else. The formation of red blood cells. So let's recall that red blood cells, erythrocytes, are a nucleate, which means they can't synthesize proteins, they can't grow, they can't divide. So as they age, they become rigid and they begin to fall apart around day 100, day 120. The remains are eliminated by phagocytes in the spleen, liver, and other body tissues. And some of the components will be salvaged for reuse or recycled to their building blocks. Iron is bound to protein as ferritin, and the balance of the heme group is degraded to bilirubin, which is then secreted into the intestine by liver cells. There it becomes a brown pigment called stercobilin that leaves the body in feces. Globin is broken down to amino acids, which are released into the circulation. Lost blood cells are replaced more or less continuously by division of those hemocytoblasts in the red bone marrow. The developing red blood cells divide many times and then begin synthesizing huge amounts of hemoglobin. When enough hemoglobin has been accumulated, the nucleus and most organelles are ejected, and the cell will collapse inward. The result is a young red blood cell called a reticulocyte, because it still contains some rough ER. The reticulocyte enters the bloodstream to begin the task of transporting oxygen, but within 2 days of release, it's gotten rid of the rest of that ER and it's become a fully functioning erythrocyte. The entire development process from hemocytoblast to mature red blood cell takes about 3 to 5 days. The rate of production of the erythrocyte production is controlled by the hormone called erythropoietin. Normally, a small amount of erythropoietin circulates in the blood at all times, and so that red blood cells are formed at a pretty constant rate. Although the liver produces some, the kidneys play a major role in producing this specific hormone. When the blood level of oxygen begins to decline for any reason, the kidneys, a convenient location to monitor blood, step up the release of erythropoietin, and then that targets the bone marrow, stimulating it to start turning out more red blood cells. So you can see the mechanism by which it does this. So number one, the stimulus is low O2, related to a decreased red blood cell count, a decreased amount of hemoglobin, a decreased amount of availability of oxygen, and then your kidneys and your liver release erythropoietin that stimulate the red bone marrow to start pumping out these red blood cells, therefore enabling more oxygen to get where it needs to go. Now let's talk about the formation of white blood cells and platelets. So like erythrocyte production, the formation of leukocytes and platelets is stimulated by hormones. These colony-stimulating factors, CSFs and interleukins, not only prompt red bone marrow to turn out leukocytes, but also enhance the ability of mature leukocytes to protect the body, which is a pretty cool function. Apparently, they are released in response to specific chemical signals in the environment, such as inflammatory chemicals, certain bacteria and their toxins, and the hormone thrombopoietin produced by the liver accelerates the production of platelets from megakaryocytes, but little is known how the process is regulated. When bone marrow problems or a disease condition such as leukemia is suspected, a special needle is used to withdraw a small sample of red marrow from one of the flat bones, either your ilium or your sternum, close to the body surface, and this procedure provides cells for microscopic examination, and it's called a bone marrow biopsy. Hemostasis, so heme meaning blood, stasis meaning standing still. So hemostasis is stopping bleeding. So let's look at the image on the right first, which is just the events of hemostasis. So in one, a vascular spasm occurs. The immediate response to blood vessel injury is vasoconstriction, which causes blood vessel spasms. The spasms narrow the blood vessel, decreasing blood loss until clotting can occur. Other factors causing vessel spasms include direct injury to smooth muscle cells, stimulation of local pain receptors, and release of serotonin by anchored platelets. A platelet plug begins to form. Platelets are repelled by an intact endothelium, and when the underlying collagen fibers of a broken vessel are exposed, the platelets become sticky and cling to the damaged site. Anchored platelets release chemicals that enhance the vascular spasms and attract more platelets to the site. As more and more platelets pile up, a platelet plug is formed. And then coagulation events occur at the same time. So a lot of this stuff is happening quickly or at the same time. The injured tissues are releasing tissue factor, which interacts with platelet factor 3, a phospholipid that coats the surfaces of the platelets. This combination interacts with other clotting factors and calcium ions, which are essential for many steps in the clotting process, to form an activator that leads to the formation of thrombin, an enzyme. Thrombin then joins soluble fibrinogen proteins into long hair-like molecules of insoluble fibrin. Fibrin forms a meshwork that traps red blood cells and forms a basis of the clot. Within the hour, the clot begins to retract, squeezing serum, plasma minus the clotting proteins, from the mass and pulling the ruptured edges of the blood vessel closer together. In the image on the left, you can see red blood cells trapped in this mesh of fibrin threads. Normally, blood clots within 3 to 6 minutes. As a rule, once clotting cascade is started, the triggering factors are rapidly inactivated to prevent widespread clotting, which is a very important homeostatic function in your body. If your body did not stop this response, this clotting, you're going to have issues with clotting in other places of your body that don't need to be clotted. Eventually, the endothelium regenerates if the clot is broken down. Once these events of the clotting cascade were understood, it became clear that placing sterile gauze over a cut or applying pressure to a wound would speed up the clotting process. The gauze provides a rough surface to which platelets can adhere, and the pressure fractures cells, increasing the release of tissue factor locally. So let's talk about a couple of the common undesirable clotting disorders or events. So we have a thrombus. So a thrombus is a clot that develops and persists in an unbroken blood vessel. So it's kind of just sitting there in the vessel. If it gets large enough, it can block blood flow entirely. This can have catastrophic consequences. If you're blocking blood flow to the lungs, to the heart, to the brain, the consequences may be death of lung tissue or heart tissue or brain tissue and fatal hypoxia to those tissues. If the thrombus breaks away or a piece of it breaks away from the vessel and is floating freely in the bloodstream, it is then an embolus. This doesn't necessarily become a problem until it meets a vessel that is too small to let it pass, and that it has similar effects to the thrombus. Undesirable clotting can be caused by many things. Anything that roughens the endothelium of blood vessels and encourages clinging of platelets. So things like burns, physical blows, or an accumulation of fatty material. Slowly flowing blood or blood pooling is another risk factor, especially in immobilized patients. This is the same reason you want to get up and walk around during a flight. It can put you at higher risk for a blood clot. In this case, clotting factors are not washed away as usual and accumulate so that clot formation becomes possible. A number of anticoagulants, and most important of which are aspirin, heparin, and warfarin, so Coumadin, are used clinically for thrombus-prone patients. So that's why if you've ever been in the hospital or if you've taken care of somebody in the hospital, especially if they're expected to be bedbound for an extended period, they'll usually get a daily dose of heparin or a daily dose of Lovenox or some kind of blood thinner so that they don't develop a clot. A few bleeding disorders. So we have thrombocytopenia, which results from an insufficient number of circulating platelets It can arise from any condition that suppresses the bone marrow, cancer, radiation, certain drugs. In this disorder, even normal movements can cause spontaneous bleeding in the small blood vessels, evidenced by petechia, which show up as small purplish blotches. They can sometimes resemble a rash on the skin. When the liver is unable to synthesize its usual supply of clotting factors, abnormal and often severe bleeding episodes occur. If vitamin K, which is needed by liver cells to produce the clotting factors, is deficient, the problem is very easily solved with just vitamin K supplements. But when liver function is severely impaired via hepatitis, cirrhosis, liver failure, only whole blood transfusions are helpful. Transfusions of concentrated platelets will provide some temporary relief from bleeding. Then we have hemophilia. This is kind of a broad but all-encompassing term for several different hereditary bleeding disorders that ultimately result from a lack of any of the factors needed for clotting. So they all have similar signs and symptoms that begin early in life, because even a minor tissue trauma results in prolonged bleeding and obviously can be life-threatening. Repeated bleeding into the joints causes some of them to become disabled, and they can be very painful. When a bleeding episode occurs, hemophiliacs, or people with hemophilia, are given a transfusion of fresh plasma or injections of purified clotting factors that they lack. Because hemophiliacs are absolutely dependent on one or the other of these therapies, some of them have become victims of blood-transmitted viral diseases such as hepatitis or HIV. These problems have been largely resolved because of the availability of genetically engineered clotting factors and hepatitis vaccines. So while transfusions of whole blood can save lives, people do have different blood groups, and transfusing something that's incompatible or mismatched can be really fatal. The plasma membranes of red blood cells, like those of other body cells, bear genetically determined proteins. So we all have our own red blood cell membrane antigens, so a substance that your body recognizes as foreign. So you don't recognize your own antigens as foreign. However, if you are to get transfused by somebody that does not have the same antigens as you, your body will develop antibodies, which are present in the plasma and attached to red blood cells with antigens unlike our own. The binding of these antibodies causes foreign red blood cells to clump in a phenomenon called agglutination, which leads to the clogging of small blood vessels throughout the body. So you can see why that could be a pretty big problem. During the next few hours, those red blood cells will start to rupture, and then their hemoglobin is released into the bloodstream. So although the transfused blood is unable to deliver the increased oxygen carrying capacity that we're hoping for when we transfuse the blood, and some tissue areas may be deprived of blood, the most devastating consequence of severe transfusion reactions is the freed hemoglobin molecules that may block kidney tubules, cause kidney failure, and then cause death. Transfusion reactions can also cause fever, chills, nausea, and vomiting, but in the absence of kidney shutdown, these reactions are rarely fatal. Treatment is aimed at preventing kidney damage by infusing fluids to dilute and dissolve the hemoglobin, and diuretics to flush it out of the body in urine. So generally, if you're transfusing with a patient, whether they've been type cross-matched, antibody check, everything, we'll still sit with those patients for at least the first 15 minutes of transfusion, just to watch for those signs of fever, chills, etc. There are over 30 common red blood cell antigens in humans, so each person's blood cells can be classified into several different blood groups. However, it is the antigens of the ABO and RH blood groups, which we'll talk about on the next slide, that cause the most vigorous transfusion reactions. So the ABO blood groups are based in which two of the antigens, type A, type B, a person inherits. So absence of both antigens is type O blood. Presence of both antigens leads to type AB blood. Antibodies formed during infancy against the ABO antigens not present in your own red blood cells. As shown in the table, a baby with neither the A nor the B antigen, group O, forms both anti-A and anti-B antibodies. Those with type A antigens, group A, form anti-B antibodies, and so on. So that's why, so nobody's forming anti-O. There are no anti-O antibodies, which is why type O blood is called a universal donor. And type AB is a universal receiver. So type AB does not make any anti-A or anti-B because they have both types. And then we have the Rh blood groups. So they're so named because of one of 8 Rh antigens, agglutinogen D, which was originally identified in rhesus monkeys, later discovered in humans. Most Americans are Rh positive, meaning their red blood cells carry Rh antigen. Unlike antibodies of the ABO system, anti-Rh antibodies are not automatically formed by Rh negative individuals. However, if an Rh person receives Rh positive blood shortly after the transfusion, his or her immune system becomes sensitized and becomes producing those anti-Rh positive antibodies against that foreign antigen. So it may not be a problem the first time they're transfused, but it will be a problem the next time and every time after that. So hemolysis is the rupture of the red blood cells. So this is what would occur in that second and third and fourth transfusion in the person that is Rh negative receiving Rh positive blood. So I put on here RhoGAM. So this is an important Rh related problem because it can occur in pregnancy. So in pregnant Rh negative women who are carrying Rh positive babies, the first such pregnancy usually results in delivery of a healthy baby. No problem. Then the mother is sensitized by the Rh positive antigens that have passed through the placenta into her bloodstream, and she develops those anti-Rh positive antibodies unless treated with RhoGAM in the 28th week of pregnancy, and again shortly after giving birth. RhoGAM is an immune serum that prevents the sensitization and subsequent immune response. If she is not treated and she becomes pregnant again with another Rh positive baby, her antibodies will cross the placenta and destroy the baby's red blood cells, producing a condition called hemolytic disease of the newborn. The baby is anemic, becomes hypoxic and cyanotic. Brain damage and even death may result unless fetal transfusions are done before birth to provide more red blood cells for oxygen transport. So now that we've talked about all those potential reactions, it's pretty important that it's pretty obvious rather that it's important to determine the blood group of both the donor and the recipient prior to transfusion. The general procedure of determining ABO blood type essentially involves testing the blood by mixing it with 2 different types of immune serum, anti-A, anti-B. Agglutination occurs when red blood cells of a type A person are mixed with an anti-A serum, but not when they are mixed with an anti-B serum. Likewise, red blood cells of type B are clumped by anti-B serum, but not by anti-A. In order to double check compatibility, cross-matching is done. Cross-matching involves testing for agglutination of donor red blood cells by the recipient serum and of the recipient's red blood cells by the donor serum. Typing for Rh factors is done in the same manner as ABO blood typing. So when serum containing, you can see here, when serum containing anti-A or anti-B antibodies is added to a blood sample, diluted with saline, agglutination will occur with the antibody and the corresponding antigen, if present. So type A, you can see contains antigen A, agglutinates with anti-A serum. Type B contains antigen B, agglutinates with anti-B serum. Type AB contains antigens A and B, agglutinates with both sera. And type O contains no antigens, does not agglutinate with either serum. Developmental aspects of blood. So in the embryo, the entire circulatory system develops pretty early. And before birth, there are many sites of blood cell formation. The fetal liver, the spleen. But by the 7th month of development, the fetus's bone marrow has become the chief site of hematopoiesis and remains so throughout life. Generally, embryonic blood cells are circulating in newly formed blood vessels by day 28 of development. Fetal hemoglobin differs from the hemoglobin formed after birth. It has a greater affinity, aka can more easily bind to oxygen. Obviously a characteristic that we find highly desirable because fetal blood is less oxygen rich than that of the mother. After birth, fetal blood cells are gradually replaced with red blood cells and contain the more typical hemoglobin A. In situations which fetal red blood cells are destroyed so fast that an immature liver cannot get rid of the hemoglobin breakdown products fast enough, the infant will become jaundiced. This is referred to as physiological jaundice, and it generally causes no major problems. Some congenital diseases result from genetic factors, things like sickle cell or hemophilia. And then with increasing age, chronic types of leukemias, anemias, diseases of undesirable clotting formation increase in prevalence, usually related to a secondary disorder. So disorders of the heart, blood vessels, the immune system. The elderly are particularly at risk for pernicious anemia caused by a lack of vitamin B12 because the stomach mucosa, which produces that intrinsic factor that helps with the absorption of B12, atrophies with age. And per usual, any questions, comments, or concerns, feel free to let me know.